All right. So, hi, good morning, everyone. So, another beautiful day and just kind of a week, almost a week left for the exam. I'm very, very sure that each one of you is very ready. Mighty Tarun, the calm waves. Okay. So, the exam for FMG is on 17th. And I know there must be times when you will be feeling little worried, but it's not the time to stay worried. It is a time where you should be actually feeling confident and you should be trusting your preparation because Zafa, good morning. So all these days, all the time when you have been at your medical college abroad, when you have come back to India, you all were aware that this is the day we were waiting for. And now the day almost is in front of you, just a week away from today. So with almost a week left, there might be so many things which might be coming to your mind. क्या पढ़ना है क्या नहीं पढ़ना है अब लास्ट मोमेंट पे क्या रिवाइज करें टेस्ट देना है कि नहीं देना है Okay, so Dr. Parwana 2805, good morning. So today I'm here with one very simple session where I'm going to just show you very quickly some of the images, right? Some of the x-rays, and later we can talk about certain other instruments and implants and splints and traction because almost in every session, whether you talk about the NEET exam, whether you talk about the INA exam or even the FMG exam, nowadays we do have the questions on images, right? Image based instruments or maybe some or the other thing may be asked to you, right? So now today I'm going to talk to you about the x-rays. All right, so let me just adjust my camera appropriately and I'll show you some of the important x-rays which are very, very important for your exams. So just give me a moment and we'll start. Okay, so we can start from here. So this is one quote with which I wanted to start your day. See, it is always seeming this always seems impossible until it is done, right? And you all are almost on the verge of completing and achieving what you were looking for, right? So always trust yourself and nothing can go wrong with your honest preparation, with your complete heart into it. So you all have been honest with yourself, so nothing can go wrong. Trust that, right? So let's start the day. Just give me a moment and I'll adjust my camera so that you all can see it very, very appropriately. So let me show you some images. Yeah, so I hope from here it should be absolutely okay for everyone, right? So that way it should be okay, that way it should be fine. All right, guys, so I'll just open up one of the most important image slide I have for you. So I start from the trauma section only, right? The injuries, the fractures in orthopedics. Okay, so in trauma section, the most important thing I want you to remember are the dislocations, number one, right? The two dislocations I want you to remember all the time. Okay, so number one, this is, you all know, one of the most commonly repeatedly asked questions, right? And if you just look at this particular x-ray, that should be better now. So look at this particular x-ray. So always remember whether it is about the hip joint and or it is about basically the shoulder joint. This is the margin of the glenoid, right? And if the head of humerus has come down, if the head of humerus has come down like this, it is usually an anterior dislocation. So when it comes anterior, it goes little down and it is usually, anterior dislocation. So how do I figure out it is anterior only? Because here I can still see the contour of the head of the humerus, the globular part, and also the greater tuberosity, right? So head of humerus has turned outwards like this, external rotation, right? So when it goes in external rotation, it has to be anterior dislocation. This is the coracoid margin. This is the clavicle over here, right? So anterior dislocation can be of three types: prominently, subcoracoid, preglenoid, or infraclavicular. And most commonest is anterior only. In the anterior, it is subcoracoid. All right, number one. Number two, when by chance you get some this kind of x-ray in your exams, where they say that the contour of the shoulder is maintained, right? The contour of the shoulder is maintained and the head of humerus, doesn't seem to go out, but now it is showing you on the upper end, it is showing you a bulb-like structure like this, right? That usually is favoring the posterior dislocation. So patient has got a trauma to the shoulder. Patient is not able to mobilize the shoulder. The contour is maintained. That usually goes in favor of the posterior dislocation. All right, that is second one. So anterior dislocation and posterior dislocation, these two should never be missed, right? These two should never be missed. All right, then we have another very important injury, or I would say the trauma around the elbow here is the supracondylar humerus, right? So please do remember about the supracondylar humerus. In supracondylar humerus, you know, this is the most commonest injury around the elbow, right? And supracondylar elbow can be of two types. It can be a extension type injury, right? This can be a extension type injury or it can be a sorry it can be a flexion type injury, right? So extension type injury means when the distal fragment has gone on the dorsal aspect, similar to the Coley's and the Smith, right? Distal fragment going dorsally, it makes it an extension kind injury. And if the distal fragment comes on the front side, anterior side, it is a flexion kind of injury. So you all should know that most commonest type, 98 to 99% time, the supracondylar fractures are extension type. Okay, so if image based question is asked, and yes, definitely this supracondylar humerus is the most important, I would say, not even very important, it is the most important topic in trauma you should read, right? One of the most important topic you should read. Okay, so supracondylar, extension type, flexion type. Don't forget the nerves which are involved with this. All right, so that is supracondylar, extension type and flexion type. And I'm sure each one of you can easily recognize what is the meaning of extension and flexion type now. All right, then we have another very important injury where you might be given an X-ray somewhat like this, right? And they simply ask you in the elbow that which part is getting the fracture, right? So don't forget, this is your ulna and labeling should never be wrong, right? This is ulna and that has to be radius. Okay, so always remember ulna is going to have articulation with the trochlear region like this, the fossa here, and this radial head should have been having the articulation with the capitulum, right? Should have been having the articulation with the capitulum, right? Now this is supposed to be the medial side, this is supposed to be the lateral side. This hole is the margin of trochlea. Sorry. Now you can see there is a fragment which is displaced from lateral side, right? And this is the capitulum along with the fragment of the lateral condyle. You can see that, right? So this one is a, no, you can say the displaced fracture of the lateral condyle of the humerus, right? So lateral condyle, elbow anatomy, you all must remember. You should never forget. So this is going to be the lateral side. The capitulum was supposed to be here along with the lateral condyle and the epicondylar ridge. So lateral side is damaged here, right? That is a lateral side. All right, so no confusion should be here. In the past, they have asked you one question where they just mentioned, they just marked one arrow, right? And they asked what fragment is injured, what fragment is fractured. All right, that is one. Now, can somebody tell me what kind of dislocation is this? Can someone tell me what kind of dislocation is this? Can you figure out this dislocation? You all can see that this is the elbow dislocation, right? You all can figure out this is elbow dislocation. Now, what kind of elbow dislocation is this? Is this anterior dislocation of elbow? Is this posterior dislocation of elbow? What kind of dislocation is this? If you can figure out, posterior, right? So why do you say it is posterior? Because here the radius and ulna, the two paired bones, they are on the extensor surface. They are on the posterior side. Absolutely right, Zafa, Nomila, absolutely right, right? This is elbow dislocation, posterior one, right? In the elbow dislocation, posterior supracondylar. Oh, we don't call it posterior supracondylar, beta. It is simply a elbow dislocation which is posterior, right? Now this is considered as a proximal fragment and these two are considered as distal fragment. So whenever distal fragment has gone back, it will be simply called as your posterior dislocation, right? Now tell me what happens to 3-point relationship here. What is going to happen to 3-point relationship here? In 3-point relationship, what change will happen with this posterior dislocation of elbow? Will it be changed? Will it be broken? Will it be same way maintained or it is going to be reversed? What actually happens in 3-point relationship? So lateral epicondyle, medial epicondyle and the olecranon. So what will happen? Changed or not changed or reversed? So what do you say? changed, unchanged, or reversed? What do you say? Reversed. Very good. So 3-point relationship, don't forget, is reversed here, right? 3-point relationship is going to be reversed. Very good. Elbow dislocation. All right. Then we have two most important injuries where the labeling is done, but I'll just try to show you again. So I'll just remove this labeling and have a look on these two x-rays again. Right, these two are the injuries around the distal end of radius. They are very, very important. Without a doubt, they are very, very important. Okay, injuries at the distal end of the radius. Now, look at these two pictures. Right, look at these two pictures and figure out that what these fractures can be. Are they Colles? Are they Smith? What exactly they are? Can you make out what exactly they are? So, image A, if I just label this as image A and this as image B, can you figure out whether it is a intra-articular fracture or it is an extra-articular fracture? Can you figure out? Can you figure out? Now look at these two. The very first thing to be seen in any fracture of distal end of radius is the articular margin, right? Always first look at the articular margin, whether it is breached or it is intact, right? Now look at this one, whether it is breached or it is intact. Now, if it is intact, it means both of these injuries, they are actually your extra-articular fracture. Very good. Very good. Absolutely right. These two are extra-articular fracture. Now, what all extra-articular fractures we know? Extra-articular fractures are two basically, right? It can be Smith or it can be Colles, right? It can be Smith or it can be Colles. Now, what is the basic difference in these two, Colles and the Smith? What is the basic difference? It is the displacement which defines whether it is Colles or whether it is Smith. Now, if the distal fragment is going dorsally, it will be called as which injury? It will be called as Colles, right? It will be called as Colles, dorsal displacement, right? And if the distal fragment is now facing in the palmar side, it is getting displaced on the palmar side, you are absolutely right, it is going to be called as the Smith fracture, right? So what is the basic difference in Smith and Colles? The displacement of the fragment either on the palmar side or on the dorsal side, right? So no mistakes in these two x-rays, and this is the reason why when the fragment goes in the palmar side, it is going to give us a garden spade deformity. When the fragment goes on the dorsal aspect, it is going to give us a dinner fork deformity, right? A hump on the back and the displacement on the front side, right? So Colles and Smith, the dinner fork deformity here, the dinner fork deformity here, and the garden spade deformity here, right? The Colles and the Smith. I hope these are fine with everyone. Now, these two injuries should never be missed with Barton's injury. Now, what exactly will be the difference in Barton? See, understand. This is the AP view. Now, in this AP view, if you trace the articular margin, just have a look. This articular margin is breached, right? This articular margin here is breached, okay? And you can see breach in the articular margin is along with the fragment of the bone, which is coming in the joint area, right? So this is intra-articular now. Now, this is the, you can see these fractures like this in the AP view or the PA view. But if in exams, if this image is given to you, don't miss out the intra-articular extensions. And after getting a fracture, just have a look whether the fragment is coming on your palmar side or the fragment is going on the dorsal side. So if the fragment comes over here on the dorsal side, it becomes your dorsal Barton, right? If the fragment comes over here on the palmar side, it becomes your volar Barton, right? So don't miss out. Don't get confused and always think that only Colles can be asked to you. If it is Barton, first thing, anytime you get a fracture of distal end of radius, the first thing to be seen always and always is whether it is intra-articular or extra-articular, right? Don't miss out. So this definitely is Barton. This is definitely Barton. And don't forget, this Barton can be volar or this Barton can be dorsal. This can be asked either ways, volar or dorsal, right? Now, another very, very important injury. If in your exam, they mention about the tenderness in the anatomical snuff box, okay? Tenderness in the anatomical snuff box. Tenderness in anatomical snuff box. We are talking about only one injury. And what is that? Tenderness in the anatomical snuff box. We are talking about only one injury. What is that? Somebody having history of trauma, RTA, and tenderness in the anatomical snuff box. That is linked to the fracture of scaphoid, right? That is linked to the fracture of the scaphoid. All right. That is scaphoid injury. So anatomical snuff box mention, it should be scaphoid. Now, if this kind of X-ray is given to you, scaphoid fracture, absolutely right. Varun, Tarun, both of you are absolutely right. Divya, absolutely correct. Now, look at this. In this injury, what you can make out, the lunate bone, which is supposed to be here like this, articulating with the distal end of radius like this, lunate was supposed to be here. Now, what has happened to lunate? Lunate is standing very prominently out, standing straight, ready to jump out like this, right? This kind of injury where the lunate has just changed its position, right? This is simply nothing else, just a lunate dislocation, right? That will be lunate dislocation, absolutely correct, right? So this is lunate dislocation, very true. Okay, and then one injury I want you to remember, this has been a past question of your exam as well, right? This kind of fracture over here. Now you can see there is a fracture at the base of the first metacarpal, right? The thumb, first metacarpal here. Now this is the distal part, this is small proximal part. And what injury is this? What fracture is this, if you can make out? What fracture is this? Come on, try to figure out. The fracture at the base of first metacarpal. What are the fractures which can occur at the base of the first metacarpal? What do you say? Fracture at the base of the first metacarpal. What do you say? We have two injuries here. One will be Bennett, other will be Rolando, right? One is Bennett, one is Rolando. So what is the basic difference in the two? Bennett and Rolando. What is the basic difference? Bennett, very good. So there is an attachment of a muscle over here, right? Which never allows, yes, which never, generator, ये generator fracture कब से हुआ? नहीं. So this is a muscle which is attached over here, right? Which is going to pull. And which muscle is this? Tendon of which muscle is this? It is abductor pollicis longus, right? It is abductor pollicis longus, right? Now this muscle does not allow the fragment to stay in position, and that is why most often we require to go for fixation of Bennett's. Okay, so this is a partially intra-articular kind of fracture. Partially intra-articular kind of fracture over here. Okay, so this is Rolando. Don't forget, this is Bennett, and Rolando will be when there is a combination over here. This particular X-ray is of Bennett, and if there is a combination over here, it is going to be Rolando. Absolutely correct. So these are certain injuries which I want you to remember from upper limb, not to be missed at all, right? Never to be missed at all. Okay, so now in the second, I can show you some injuries from the lower limb. In the lower limb, sorry, in the lower limb, please don't miss out the treatment plans for the fractured neck of the femur. Now this is very important, right? Don't miss out the treatment plans for the fractured neck of the femur. Fractured neck femur or the IT fractures, these two X-rays and these two treatment plans, right? X-rays as well as the treatment plans, both are important. X-rays for neck of femur, X-rays for intertrochanteric fracture, along with the treatment plan, which I've already discussed in all your PYQs, right? You should not ever miss X-rays, fracture neck femur, IT and the treatment plan. So please go through the videos of the PYQs we have done, right? That will be very important. Now two very important implants. So you can just talk about these two. One is PFN and one is DHS, right? This one, the second one I have is a DHS. Now look at these two. How DHS is placed, that image is also there. So you can try to understand what is the difference in the DHS and the PFN, right? Look at these two. So DHS and PFN, that is a basic difference. PFN, proximal femoral nail, is going to be inside the bone, right? Nail, that means it has to be inside the bone, right? Intramedullary nail over here. And this is DHS, dynamic hip screw, right? Dynamic hip screw. This is DHS, right? So this is how DHS looks like, and this is how PFN looks like. All right. So don't miss out these two images. They are very important. PFN has been a recent question of your INSET exam as well. They asked in relation to IT fractures. So you should never miss. This has been a recent MCQ. PFN and DHS. All right. Then one image based question I want to share is this one, right? What exactly is this? What is this? This is Pavlik harness, right? This is Pavlik harness. Harness simply means a band. Okay. These all are harnesses only. Harness on the horse, harness on the person, harness on the dog. These all are harnesses, right? This is pelvic harness. Can be used in two conditions. It can be used in your fracture shaft of the femur, as well as in the cases of congenital dislocation of the hip. So don't miss out these two. And one image is definitely very important, and that is here. That is this one. That is gallows traction, used for fracture shaft of femur in any child less than 2 years of age, right? Any child less than 2 years of age. All right. So don't miss out these two. All right. And we have definitely the patella. How can we miss that? Patella fracture. So 2-part fracture of patella. If they're giving you which is going into displacement here, the answer has to be TBW. So definitely patella will not be missed. I'm very sure on that part. All right. And if there are fractures given to you, this one is important definitely. Yeah. Can you identify this injury? How will you label this injury? What fracture do we see here? You can see the 5th metatarsal, right? You can see a fracture at the 5th metatarsal. Can you recognize what is this? Can you recognize what is this? So how do we label this injury now? How should I call this? Yes, this is Jones fracture, right? That would be Jones fracture. Absolutely correct. Okay. Jones fracture. Please remember, Jones fracture has got attachment of the muscle peroneus brevis, right? It is peroneus brevis, and that is why it takes little more time to heal, even if you're trying to plan and manage it conservatively, right? So 6 to 8 weeks, 6 to 9 weeks is the usual time for which we might require the plasters, right? That might be required. All right, so that is important injuries. And yes, definitely, though I'm not putting the x-rays over here, but yes, one important point I want you to remember are the eponyms, right? Are the eponyms of ankle injuries. Okay, eponyms of the ankle fracture. Don't miss out those, right? All the eponyms. So when you look at the ankle here, the tibia and the fibula. So if somebody gets a fracture bimalleolar, lateral and medial malleoli, what do you call that? Bimalleolar fracture. What do we call that? That is called as the Pott's fracture, right? That is called as the Pott's fracture. And when you look at the posterior aspect of tibia getting an injury over here, this one, then all the three will be called as the Cotton's fracture, Pott's fracture or the Cotton's fracture, right? Two very, very important. Yes, absolutely right. Pallu 1, 2, 3, absolutely correct. This is Pott's and Cotton's, right? Don't miss out these two, Pott's and Cotton's. They are very, very important injury, right? Now, there is one injury, Maisonneuve, right? What is that Maisonneuve injury? In Maisonneuve injury, what happens? The fracture starts usually occurring from this medial malleoli, and it goes obliquely and hits the head of the fibula, right? When it hits the head of fibula, or basically the neck of fibula, you know that around the neck of fibula, we have this nerve called as CPN, common peroneal nerve. And if common peroneal nerve is getting a hit, what is the presentation of the patient? What is the presentation? If somebody's CPN is not working well, what should be the presentation of the patient? So presentation goes as the foot drop, right? And as the patient develops foot drop, how he is supposed to walk? Along with the foot drop, please don't forget CPN, the foot drop, and patient of foot drop has to walk with a high stepping gait. Absolutely correct. They have to walk with a high stepping gait. All right, that is absolutely correct. Okay, so don't forget these injuries from the trauma. So trauma, these two I wanted to take up. Now, there are certain splints or traction. Okay, this is from the trauma. And now one more session. Tumors, I have shown you already most of them. Now there is one more I would prefer to take from your, yeah, okay. There is one more session I would prefer to take from your, this, yeah, splints and tractions and the instruments and implants that I would prefer to take, right? So from trauma, these x-rays, injury part are very, very important, right? Splints traction, I have already shared a PDF with all of you. The splints, tractions, instrument, implant, and I want everyone to remember all of them very, very properly. One question on the images, image-based question on splints, traction definitely can be asked in the exam. Please go through that file of splints, traction, instrument and implant, and if there is any trouble, do let me know. All right. And all the PYQs we have already covered. And if you want me to cover up some other MCQs, maybe the related part of my anatomy, or maybe the related part of surgery, just let me know, drop me a message and we can do that. Now in the next session, I'm planning to have a discussion with you, a quick one, image-based discussion on your instruments, implants, maybe some splints or traction. So please, before that, go through that file very, very properly, and then we can talk about that. All right. So keep studying. Don't, miss out a single opportunity to cover up wherever you have been lacking. And that is going to make a big difference. So this is not the time when you should be feeling low. This is not the time when you should be feeling little, not very confident and keep on doubting yourself. One session for all the tumors, yeah, definitely we can plan. So let's do it tomorrow morning. Tomorrow morning we can take a session on tumors, and I'll show you a brief image again about the tumors, and then we can talk about x-rays also, right? So tomorrow morning I'll take a session on tumors, and tumors won't be a tough thing, that is for sure. Tomorrow morning, maybe 6:30, we'll plan that time, right? So let's do it tomorrow morning. Till then, follow your schedule and keep on doing the best. Utilize the time in the best possible manner, right? So stay confident, stay positive, stay hopeful, and you all are going to clear the exam. That is the thought with which you should be studying right now. All right. So all the very best to all of you, and see you all tomorrow morning again.